Endocrinology section 3 will discuss the thyroid gland. The disorders that we will talk about it, hypothyroidism could be congenital, hyperthyroidism, thyroiditis, thyroid nodules, and goiter, and thyroid cancer. So cretinism is a condition of severely impaired physical, mental, and mental growth with enlarged tongue, distended abdomen, and it is usually due to untreated congenital insufficiency of the thyroid hormone. If they want to direct you towards hypothyroidism on the boards, look for dryness of the skin, bradycardia, constipation, and slow ankle reflex. Whatever the reflex, that's going to be slow. Remember that TSH is very sensitive and is the best test used to exclude thyroid disease in asymptomatic patient. Like start with TSH, and if it is normal, that's the patient is asymptomatic, no thyroid disease most of the time. What do I mean by subclinical hypothyroidism? In this situation, TSH is going to be mildly elevated, but the free T3 and T4 are normal free T4, mildly elevated TSH, increased risk to convert to hypothyroidism if the anti-thyroid peroxidase antibody is positive. So if they give you this kind of labs and ask you what is the next step, check the level of anti-thyroid peroxidase. If it is positive, it means that there is increased risk for convert to hypothyroidism clinically, and you might even start the treatment of the patient. And so who should be treated with subclinical hypothyroidism? If the thyroid peroxidase test is positive, or during pregnancy because increased risk of fetal death. In elderly patients who have memory or behavioral problem, patients with increased risk for hypercholesterolemia, they need to be treated. Start with low dose of thyroxine if the patient has subclinical. Low dose could be 25 microgram a day. Remember that hypercholesterolemia is common in patients with hypothyroidism, so treat the subclinical hypothyroidism if they have hypercholesterolemia. During pregnancy, I mentioned that we have to be careful with the thyroid. So if I'm telling you most women with primary hypothyroidism require an increased dose during pregnancy, is this true or false? The answer is true, and basically you might be asked about how much are you going to increase, like 33% of the current dose of the patient with becoming pregnant. And remember to increase the dose of thyroxine for females on estrogen replacement therapy due to induction of liver enzymes. So liver enzyme is going to be induced, and it's going to, this patient will need higher dose. During pregnancy, there is increased total T4, but normal free T4, increasing total binding globulin, thyroid binding globulin, and normal TSH. I want to remind you with the drugs that it will interfere with the T4 absorption. So if you give a patient Synthroid, for example, and for hypothyroidism, and there is no improvement, make sure that you check the medication that the patient is taking. If the patient is on something like cholestyramine, or he's taking ferrous sulfate or iron supplement over the counter, or he's on calcium carbonate or sucralfate, all this medication will interfere with the absorption of the Synthroid. So advise that the patient take the Synthroid several hours before taking this medication. For the hyperthyroidism, I'm going to start with Graves' disease, and it has the classic triad of goiter, ophthalmopathy, like lid lag and lid retraction, and dermopathy. Remember that when you treat the patient with Graves' disease, the lead leg and retraction might return to normal, but exophthalmos is irreversible. Once it happened, it will not going to be returned to normal. And the cause of Graves' disease is autoantibody with TSH-like activity. So the antibody is going to activate the receptors on the thyroid gland, increasing the secretion of thyroxine, producing the symptoms of hyperthyroidism. And radioactive iodine uptake test is important because it's going to be increased in Graves' disease. And you need to order this to distinguish Graves' disease from thyroiditis. Why? Because early in the course of thyroiditis, the patient will have some sort of thyrotoxic symptoms. But that's not because of the cells of the thyroid gland producing a lot of thyroxine, but because of the leakage of the thyroxine from the gland due to the pathology of thyroiditis. So radioactive iodine uptake will be normal or suppressed in thyroiditis, but it's going to be high in Graves' disease. The normal radioactive iodine uptake for 24 hours is between 10 to 25%. In Graves' disease, it's going to be like 40, 50, or 60 or more. The treatment of hyperthyroidism could be with the antithyroid drugs, and we need to add propranolol for symptomatic treatment because the patient will have increased sympathetic activity with tachycardia. The other modality of the treatment is subtotal thyroidectomy, like surgery, or radioactive iodine to kill the hyperactive thyroid cells. Let me ask you about this 35-year-old woman who is 4 months pregnant, presents with fatigue, weight loss, heat intolerance, palpitation. Her physical exam reveals an anxious woman, but in no distress. She has diffusely enlarged thyroid gland. Lab work shows TSH of less than 0.01, which is suppressed. Free T4 is elevated, like 3.1. Which of the following statement regarding her treatment is true? So there's a pregnant lady, has signs, clinical and laboratory signs of hyperthyroidism. Given her degree of symptoms, she should receive radioactive immediately to prevent further harm to the fetus. Methimazole is appropriate until delivery. It should then be discontinued if she desires breastfeeding. She should be treated with beta blocker and propylthiouracil to control symptoms until she's asymptomatic. She should undergo surgical resection because it is the safest option during pregnancy. It is very obvious that we cannot give radioactive iodine to pregnant lady, but the issue here is the methimazole. Don't select methimazole during pregnancy, particularly in the early pregnancy time, and the safest one is the propylthiouracil with beta blocker during pregnancy. So I want to remind you the anti-thyroid drugs and a couple of questions here. Why you need to avoid methimazole? Because it can cause apalesia cutis in the fetus, which is loss of part of the scalp of the fetus. So always avoid methimazole. Treat a pregnant patient with propylthiouracil. So remember P for P. That should be safest. The adverse effect of anti-thyroid medication, one of them is the granulocytosis. So if you started the patient on one of this medication, actually either methimazole or propylthiouracil can cause granulocytosis. So if your patient started on one of them, then he developed severe like throat infection or fever, bring him immediately, check CBC. If he has a granulocytosis, discontinue the medicine and don't restart it and select some other modality. Surgery is indicated for young patients and patients with cold nodules, because cold nodules might develop malignancy down the road, or previous radiation, which is again a risk for malignancy of the thyroid gland, but it's rarely performed for Graves' disease. With Graves' disease, we recommend the radioactive iodine. So radioactive iodine, commonly used for Graves' disease and toxic multinodular goiter. And when we talk about the thyroiditis, most of them are autoimmune. And I'm going to discuss Hashimoto thyroiditis, subacute granulomatous thyroiditis, and postpartum thyroiditis. These are the three types that I want you to remember. So Hashimoto thyroiditis is the most common cause of hypothyroidism in the United States. And for subacute granulomatous thyroiditis or decurvan, the patient usually presents with tender thyroid, radiating pain to the ear, elevated sedimentation rate, fever, and malaise. The postpartum thyroiditis, 10% of the women might have it, positive anti-thyroperoxidase antibody in some of the patients, and it might present even up to 6 months after delivery, and it is self-recovery. The nodules and goiters, remember that 90% of the nodules in the thyroid glands are benign. If it is less than 1 centimeter in diameter, more likely to be benign. But regardless of the size of the nodule, history of radiation exposure will increase the risk of malignancy, and such patients should have been evaluated aggressively because the increased risk of malignancy. So when you have thyroid nodule, first thing is to check the TSH to determine whether there is increased activity of the thyroid nodule, because if the thyroid nodule is significantly active, that will suppress the TSH. The other test is to get radioactive iodine scan. And the scan is going to show you the picture of where the radioactive iodine is going. And it's going to tell you if the nodule is taking a lot of radioactive material or not. If it is taking a lot of radioactive material, that's what we call it hot nodule or toxic adenoma, which is basically good news to the patient because malignancy is low. And the treatment is radioactive iodine to kill the active cells in the nodule with the radioactive iodine 131. If this is cold, like the nodule is not taking radioactive iodine and non-functioning, it could be adenoma or carcinoma. And if it is cold, consider cancer. And the next step is to do the fine needle aspirate to determine the nature of the pathology. When you get the fine needle aspirate, if it is benign, that's good. If it is telling you that's malignant, manage accordingly. If it is indeterminate or insufficient, we usually recommend surgery to take a piece of the nodule to know the nature. Multiple nodular goiter. If this is multiple, not just one nodule, what is the next step in the management? Look at this. Nuclear medicine, like thyroid scan, is very important to differentiate between cold and hot nodules. Cold nodules increase the possibility of cancer and go to the fine needle aspirate as well. And then if the fine needle aspiration is telling you that the patient has thyroid carcinoma, look at the different types. It could be parafollicular or follicular. The parafollicular cancer is called the medullary thyroid cancer, and it's a neuroendocrine neoplasm from the parafollicular C cells increasing serum calcitonin. So if they tell your patient has thyroid mass and serum calcitonin is high, think of medullary thyroid cancer. And remember, as we mentioned, the MEN syndrome, MEN2, A and B, both of them are associated with medullary thyroid cancer and pheochromocytoma. as I mentioned before. That's the MEN2A and 2B medullary thyroid cancer and pheochromocytoma. So if it is follicular cancer, we have 3 histologic types. Papillary carcinoma, the most common, indolent spread through the lymphatics. If it is follicular, usually spreading yearly through the blood to the bone and lungs. If it is anaplastic, that's the worst, mostly in elderly patients and highly malignant and spread locally, and it can suffocate the patient because it's going to compress on vital structures such as the larynx and the carotid vessels. The treatment, if possible, you can do near total thyroidectomy. And why near total? Because we want to spare the parathyroid, which are located in the posteromedial aspect, 4 lobes. Even if you can spare 1 lobe, that would be good, because parathyroid is essential for the patient. Then give the patient total body thyroid scan. So it's like evaluation to see if you removed all the active areas or not. If the scan is normal, suppress TSH with oral thyroxine, because thyroid tumor is TSH dependent. If distant hot nodules like in the bone or some other area is seen, give large doses of radioactive iodine to kill these active or malignant cells. And to monitor the recurrence, check the level of thyroglobulin level. Thyroglobulin is large protein sitting inside the thyroid gland holding the thyroxine. Basically, during the formation of the thyroxine in the thyroid gland, and it will be released to the circulation with destruction of the thyroid gland with the malignancy.